Welcome to Fracture Prevention Central webinar, Healthcare Quality 101. What, why, and how. Fracture Prevention Central, brought to you by the National Bone Health Alliance, is made possible through the support from Amgen Incorporated and Eli Lilly and Company Incorporated. And now, I'll introduce you to David Lee, Executive Director of the National Bone Health Alliance. Welcome, David.
Thanks so much, and welcome to everyone. Really excited to be able to provide this webinar to everyone today in an area that I know is confusing for many around healthcare quality, and especially the evolution of the reimbursement system over the next few years. But I think the good news in that is that it really is leading to a lot of new activity, interest in care coordination, certainly including our Fracture Liaison Service model of care. So I guess before I get started, before I introduce the other webinar faculty, Simone Karp from CE City, just want to level set as well as take you through some of the slides that we have pulled together and have shared with a number of folks over the last few months as a way to give you some more tools as you have conversations around setting up a Fracture Liaison Service program in your institution that I think will be helpful. So just a little bit about the Fracture Liaison Service model of care. This is a model of care that really there's a care coordinator, NP, PA, RN, or other healthcare professional that really takes charge of each patient's bone health after a fracture. So instead of some of the statistics that folks have seen, that there's about an 80% care gap in terms of folks that have fractured not getting appropriate diagnosis, screening, and or treatment. This program really ensures that happens and that appropriate follow-up happens for these patients that have fractured. It's been running for over 15 years around the world, started in Scotland, has moved around the globe to a number of other places. Here in the U.S., I would say it hasn't been adopted as widely as we would like in the open system, and that's really one of the goals of what the National Bone Health Alliance is doing. So this is just a schematic of really seeing that FLS coordinator and physician champion as in the center, but seeing primary care, medical specialists, orthopedics, nursing, emergency department kind of all around that patient. So really the goal is to much better coordinate among the folks that are part of that team. So one of the other things that we did really to support folks was launch what we call Fracture Prevention Central about 15 months ago now, because we were hearing from folks, I know what an FLS is, I don't know how to get it started, I don't know how to make the business financial case, I don't know how to physically set it up. So what we did is we worked with a number of the leading programs, both here in the States, including the American Orthopedic Association Own the Bone program, Kaiser Permanente Geisinger Health System, as well as many of the international programs that have been running this model of care for a long time around the globe, to really provide those tools that folks need to get started, as well as folks that have already gotten started to continue developing a successful program. So this is the Fracture Prevention Central website, which I hope everyone has signed up for. So we do require free registration to be able to see all of the tools. So if you haven't signed up quite yet, it's a very easy, simple process. If you can see that sign up logo right there, actually I will point to it so you can see it. It's just about a minute that it takes just to give us your email address and make a password. But as you can see, we've had over 2,100 people that have signed up to access these materials over about a 15-month period. So we're really pleased with the interest, the support that we've gotten from folks around the FLS model of care. So really, I think what we want to review today, first are the specific quality measures around osteoporosis and fracture, which I'll go through next. And then Simone, who is certainly an expert, and I've learned so much from her over the last few years that we've been collaborating, will take you through the specifics of a number of the new reimbursement models and where all of this is evolving. So in terms of the major osteoporosis and fracture-related quality measures, The first is a series of physician quality reporting system measures. You can see those seven measures there, and Simone will actually talk a bit more about that program, how it works. The other one that we really talk about a lot is this NCQA HEDIS osteoporosis post-fracture measure, which is important for a number of reasons, one of which being that this measure is one of the 53 Medicare Advantage 5-star measures, and actually one of 31 what you might call medical measures. The rest are patient satisfaction and other things. So this is assessing whether women over 67 that have fractured get either a bone density test and or are put on therapy. So as you can see, the 2012 health plan measurement performance is where we get that 80% care gap statistic. 19% of PPOs and 25% of HMOs hit that bar. So looking at about an 80% care gap there, and even actually newer data that we're familiar with is that per CMS administrative claims analysis, only 14.5% were abiding by this measure. So obviously we've got a long ways to go to get into where we would like to be in terms of capturing most of these patients. Another major one, which is a bit of a self-report, but just assesses recollection of patients around ever getting a bone density test. So that's another important one. The other one that we want to talk about are two potential new measures that may become a new Joint Commission core measure set. So I think from the perspective of getting the business suite and the hospital administrators to perk up when you start talking about FLS, we think that we're as early as next year we may be in a place where these two measures will be a new core measure set that a hospital could choose among. So there's 14 right now. There would be a total of 15, and I understand that 6 have to be chosen by a hospital as they go through reaccreditation. So they've now been in front of the National Quality Forum Endocrine Steering Committee earlier this year. We anticipate by next month getting full NQF endorsement. They will then go back to the Joint Commission, and if the Joint Commission decides to make this a new core measure set, that could happen as early as next year. So just to review, so actually there were 3 that were developed, only 2 were endorsed. So the first one is a laboratory investigation for secondary causes of fracture. The second one is very similar to the HEDIS post-fracture measure in terms of within 6 months of that fracture getting a bone density scan or put on therapy. But what we like about this one specifically as well is that as far as we know, it's the first time internationally that the term fracture liaison service has been baked into part of the description of a measure. So as I said, hoping in the next many months to get good news that this will become a new core measure set, but I think this will be another important measure set of measures that will really help drive folks to be doing this work. So I guess also in the context of the work that we've done around Fracture Prevention Central is really identify what some of the critical barriers are to why we don't have 1,000 FLS programs in the U.S. Certainly lack of awareness among healthcare professionals that patients that have already fractured are at highest risk for future fracture. Lack of awareness about the model itself, which I think we're helping to solve through Fracture Prevention Central, as well as lack of knowledge by healthcare administrators and professionals about the model of care, how it can be implemented, many of the tools that we were able to push out through the Fracture Prevention Central resource. And then I think also a lack of tools to really get set up, and we're going to talk in a few minutes about a demonstration study that we're collaborating with CE City around that really gives folks a turnkey way to get their FLS going, as well as a way to demonstratively move the bar on performance around the osteoporosis quality measures. So now I'm going to kind of go into a couple of pieces that really relate to the business and economic case that we just want to push out to folks because, we've talked to a lot of different people and it tends to be the pieces that people are having challenges around. So the first one really is around reimbursement. So I'm going to show you next a really complicated reimbursement slide that couples both the kind of the flow of FLS from the time that that patient is identified and captured, and all of those touch points in terms of getting that bone density scan, deciding whether or not patient is appropriate for therapy, if they're on therapy, doing those follow-ups to make sure they're taking their medications, they don't have any questions, etc. Falls prevention and other pieces. But I know one of the challenges in getting these programs set up is really understanding the reimbursement landscape, especially for that fracture liaison service coordinator. How can you get compensated for the work that this FLS coordinator is doing? So I know it's kind of small, and you can actually download these slides on Fracture Prevention Central, the PowerPoint version of this slide, and I'll give you that reference in a few minutes. So you can see the specific CPT code. So just a very useful tool for folks as you start those conversations and as you really get down to some of those brass tack conversations around reimbursement. This next series of slides is going to be about a 10-set series here on the same slide, really to explain each of these pieces. So this is something that's been in my brain for a while, and thanks to Simone, it actually exists. Thanks to HIMSS Analytics. So basically what it is, it's a snapshot of how healthcare reform has impacted reimbursement or will impact reimbursement from 2011 to 2017. So as you can see, 2011, about a 2% revenue at risk, but by the end of 2017, 11% at risk, really based on these 5 elements that I'll run through. So kind of how I'm going to do this is, first, I'll just at a very high level explain what the element is, and then the next piece will kind of tie in how an FLS can help you perform, get that 1, 2, 3% bonus payment as opposed to, paying that 1, 2, 3% penalty to CMS because you're not hitting certain marks. So the first one is IQR, or Inpatient Quality Reporting, which is data on conditions common to Medicare beneficiaries, reported by hospitals, used by CMS to calculate payment rates. So in terms of how an FLS is relevant, it can actually help hospitals avoid that 2% decrease in the market basket update, and Simone will actually talk a little bit more about some of these pieces as well. Next one is value-based purchasing, which is incentive payments hospitals are getting based on how well they are performing around particular quality measures. So in terms of the piece, how an FLS can support it, could get that up to 2% Medicare reimbursement bump, and there are about 30 osteoporosis-related measures, including more than 12 that are central to the FLS model. This other one is one I think is a critical one, which is readmissions. As I think folks probably know, there are hospitals now that are paying out millions of dollars in readmissions if they're not hitting the mark on those 30-day readmission rates. And it's interesting to know that about almost 15% of all 30-day readmissions are due to hip fractures. So, when you think of everything that can get a patient back in the hospital within 30 days, that's a pretty big number. And the other thing I know is that fragility fractures are being considered for future measured conditions. I think right now they call out 4 specific conditions in addition to the overall 30-day readmission rate. So I know that that's kind of on the short list. And of course, we love for that to become, one of the other specific conditions that are specifically spelled out. Next thing is HAC, hospital-acquired conditions, which is related part of the Accountable Care Act provision that would reduce payment to hospitals with high volumes of hospital-acquired conditions. Fractures and dislocations certainly are qualifying conditions that can be reduced by identifying and treating patients with osteoporosis. So, obviously a way for folks not to get some of these hospital-acquired conditions in the hospital by appropriately managing their osteoporosis and their post-fracture care. And the last piece is meaningful use, which is financial incentives for the use of certified electronic health record technology to improve care. And actually, Simone will talk a little bit more about a mechanism at least related to PQRS and other ways to report on these measures in a good way, in a very efficient way. So last thing I'm really going to talk about is the work that we're doing with CE City, NOF, and the Johns Hopkins Armstrong Institute for Patient Safety and Quality, which is, as I had mentioned just a minute ago, is really taking the fracture liaison service model of care, baking it into a number of tools that CE City has developed that will help sites automate, benchmark, and improve their performance around quality measures. So this is something we announced in December. The press release link is there. I know the press release is also under the handout tab in the webinar. And so really our goal is to see how quickly we can get these 3 pilot hospitals initially, get their FLS up and running, and then really seeing how we're able to make some market improvements in that, right now 80% care gap, that 20-25%, which is kind of the national average where people are starting in terms of post-fracture care, as well as looking at a number of other of those measures that I reviewed. So there are a number of pieces to this, and this platform has been developed by CE City. They've used it in many other disease states, and Simone can talk a little bit more about that when I turn it over to her. But so it will automate data collection in a centralized registry, would have the ability to track in real time data and benchmark performance against osteoporosis and post-fracture measures, and actually see how you're doing both within your institution as well as among your peers in other institutions. The really critical piece that I'm especially excited about is a mechanism to improve care coordination and care transitions, really across walls. So it doesn't matter that the FLS coordinator is at the local hospital and the orthopedic surgeon is in private practice, and maybe the rheumatologist is at another institution. They can all coordinate the care of that patient in a HIPAA-compliant way. They can, even share DEXA reports and other confidential, patient identifying information. So I really think this will really help, because I think a lot of the drop balls that are happening now are, a patient fractures, gets their arm casted in the emergency department. They get some nice instructions on what to do once they get out of the hospital, but the onus is really on them to take the next step, where now we'll have this fracture liaison coordinator that's really going to intervene and make sure that they get that appropriate screening, diagnosis, and treatment after the fact. And then the last piece is really, I guess, what we've done is electronicize the FLS model of care into clinical decision support and improvement tools. So you'll, instead of kind of tracking in Excel spreadsheets and Post-it notes, you can see, if you have 500 patients that are kind of part of your program, you can see that in the next week, the 40 tasks you need to do, you can see if Mrs. Smith, we missed getting her in for her DEXA last week, that's now going to be an overdue task that, we're going to have to address. So I think, we're really excited to see how this is going to improve, one, the rapidity to which someone can get their FLS set up, but then also really, have all these other tools that I think will really help, at the end of the day, improve the quality measures, which will lead to much better patient outcomes, and certainly also that saving healthcare costs, dollars as well. So that's really the end of my presentation. Just wanted to give you the specific link to get, for instance, that colored bar slide, the reimbursement slide, and some of those others. So those are all available on Fracture Prevention Central. You do have to have that free account to be able to access this page, but it's right here at the business plans page. So I encourage everyone to use those widely. Pleased to be able to push those out to folks. And if you have any feedback as well as other things you might need or other explanatory pieces, we'd be happy to hear that. So now I'm going to turn it over to my colleague Simone Karp, who is the Chief Business Development Officer and co-founder of CE City. She is responsible at the organization for developing strategic partnerships. We've been working together for over a year, initially in conversations around FLS, and then worked together to secure funding from Merck to move forward the FLS demonstration study. She has over 25 years of healthcare industry experience focused on quality and performance assessment, measurement, and improvement, healthcare consulting services. She's pioneered efforts to improve the quality of patient care through the integration of quality and medical education. So Simone is a pharmacist. She got her degree in pharmacy from the University of Pittsburgh School of Pharmacy and is also a registered pharmacist in the state of Pennsylvania. Simone?
Thank you, and good afternoon, everyone. So why do we have so much of a need right now to even talk about Quality 101, the title of the presentation today? And you really see it on this slide here. All of these yellow boxes are describing all of the different pressures that physicians and practices are feeling today to improve the quality of patient care. It's coming at them from their professionalism perspective, as it relates to their maintenance of certification and maintenance of licensure. It's coming at them from private payers, federal payers, as well as hospital credentialing. And but if we're able to help them to align all of this, that's really our goal at the end of the day. What we're starting to see is like the old adage of touching an elephant. If you were blindfolded, everybody thinks it's something different, a tree, a rope, a wall. It's really no different here with the result of healthcare reform. Some folks are talking about it from meaningful use, others quality reporting, value-based payment, healthcare information technology, professional certification, transparency. But the core to all of this is to really start to identify those gaps in care and to start improving on them. And I think we have a huge opportunity here with the gap being around that 80% mark that David was speaking to a few moments ago. Financially, in the ambulatory setting, so for physicians practicing and other eligible professionals who bill Medicare for services, so this isn't just for physicians, what is it that's at risk for 2014? Under the Physician Quality Reporting System, or PQRS, we are looking at a 2% penalty for non-participation and a 0.5% bonus for successful participation for 2015. So just for the PQRS alone, we're looking at about a 2.5% plus or minus incentive or penalty. What also goes into effect in 2014 is the value-based modifier. And the value-based modifier is a budget-neutral program that is going to be based on a cost and quality ratio. And those benchmarks that David was showing earlier that were published will actually be the benchmarks that the value-based payment will be paid on. And the ability to be able to participate in this positive side will really depend on the opportunity to improve your quality based on those measures that David reviewed at the beginning of the webinar. Who this applies to today versus in future years, we're going to go through in the next few slides. So today, the value-based payment and value-based modifier is dependent upon the size of the practice and the number of providers under your tax identification number. So everybody is being held accountable for PQRS for 2014. And then if you're in a practice up to 9 physicians, the value-based modifier will not apply for 2014, but in future years. If you're in a practice of 10 to 99 providers in total billing under that same tax identification number, your total at risk for reimbursement for Medicare is at 4.5%. And if you're in a practice of 100 plus providers, and not just within any one specialty, these are total providers billing under one TIN number, you are at risk for upwards of 6.5% of all of your Medicare reimbursement. So how you report on PQRS really then does depend on the size of your practice. So if you're up to 9 physicians, you'll report as individuals. 10 to 99 and 100 plus have the option to either report as individuals or under the G-Pro option. And this is what it will look like. If you just choose to go under G-Pro, you would need to self-nominate to be able to go under the group reporting option for PQRS. If you want to report as an individual, you would just do the individual reporting. For those that would choose not to report PQRS this year, again, you are going to see automatic payment adjustments downward for both the value-based modifier as well as for the PQRS. Plus, you're going to lose the 0.5% bonus for 2014. So this is really the year that everyone is starting to really pay attention to the ability to successfully report for PQRS so that you don't lose the percentages that we're been talking about here. And that's really an opportunity as a part of what we're talking about today and participating in the Fracture Liaison Service model of care and these various options that you'll have to participate in PQRS reporting. So one of the new options for 2014 is called a Qualified Clinical Data Registry, QCDR for short. And CMS definition for Qualified Clinical Data Registry in order to satisfy the PQRS requirements, which we just walked through, are going to become more important than ever to successfully report on, provides the opportunity to start to look at the data on an ongoing basis and to really start to foster improvement and improve quality of care. It's really the whole goal of the Qualified Clinical Data Registry. So many of the measures that David was just talking about a few moments ago are PQRS measures, but we now have the opportunity to also report on up to 20 non-PQRS measures as part of the Qualified Clinical Data Registry. These are the requirements to be a Qualified Clinical Data Registry under CMS. There had to be a minimum of 9 measures. They had to go across 3 of the National Quality Strategy domains. 1 needed to be an outcomes measure, and they could also include PQRS measures as well as the non-PQRS measures. The whole goal and the alignment and the work that MBHA is doing is to really start to help your practices to align all of those different requirements that we saw in that earlier slide with the physician covering his eyes. So we have these federal-based programs that include the PQRS program that we just talked about, the value-based modifier. The meaningful use programs, under meaningful use stage 2, there are several different requirements to try to meet stage 2 of meaningful use. And one is to be able to send data to a specialized registry so that you're able to show that you can send data from the electronic health record to a registry run by a medical specialty society, such as the registry we're talking about today, as well as the ability to report on ECQM. And then to be able to start to align it with all of the professionalism requirements for performance and quality improvement for maintenance of certification for the medical specialty boards, as well as the commercial payers such as Bridges to Excellence and other private pay-for-performance programs. So the whole goal and the work that MBHA is doing is to help centralize that data, bring that data in once, help the clinicians to meet multiple different program requirements, and do it on an ongoing and cyclical basis so that we get feedback, identify where those gaps are, to really start closing that 80% care gap by linking out to improvement opportunities. And that's where the Fracture Liaison Central program becomes so important, is how do we start to align interventions and education for both patients and healthcare professionals, as well as tools and resources for improvement when we're able to show that we have a gap in care to really start to close the gap on those measures. We're very excited that CMS has recently notified us that the MBHA NOF, in collaboration with CE City, has been approved for that new registry type of program, the Qualified Clinical Data Registry. It will include a number of core measures that David will go through here. And we are currently taking pre-registration for the program for anyone who may be interested in participating in the Qualified Clinical Data Registry. You will be notified as soon as it's up and running. And I will now turn the presentation back over to David to start walking through the measures in more detail.
Great. Thanks so much, Simone. And yeah, as Simone said, we're really excited about this. So just in terms of nationally, so there were 40 QCDRs that were approved by CMS. We are one of the 40, the only one in osteoporosis. I think there was a joint one as well that is one of the 40. And I know that Simone has gone through a lot of the incentives for folks wanting to use this tool in terms of PQRS and value-based payment and some of the other pieces. So there are 14 total measures that we put into the QCDR, which I will review with you on the next couple slides, just so you can see what's there. And it's really, as I said, most of the major ones that we identified earlier in the presentation. So first, here's the list of the PQRS measures themselves, both related to falls, post-fracture, osteoporosis management, screening, etc. And then these are the additional 8 ones that we selected. So as you can see, actually, we put in all 3 of the Joint Commission measures, knowing they're not fully endorsed quite yet, but obviously would love to be able to have folks start to report out on those, but anticipate by next month having at least these first 2, the lab investigation and risk assessment treatment measures approved by the National Quality Forum. We also put in the 2 NCQA HEDIS measures, the one that we always talk about in terms of 80% care gap, as well as that screening and reporting measures. As Simone had said, we did also, one of the requirements was to have 1 outcome measure. So this was really the only outcome measure that exists in osteoporosis as far as we could in our analysis. So there's a hip fracture mortality rate measure that is an HRQ measure set, and then also put in a couple of AMA PCPI measures related to calcium and vitamin D, counseling, as well as just percent of folks that were prescribed therapy within 12 months. So as Simone said, this will allow folks to report not only on PQRS measures, also this list of non-PQRS measures. And as she noted, we are taking pre-registrations for folks. We're building out this tool, and we'll have this launch very shortly. But if you go to medconcert.com/FractureQIR, you'll be able to get on that pre-registration list. And then also, just so you can do that back checking, there's the link here to the CMS site if you want to check to see which of your eligible professionals would be eligible to participate. So that's all we have in terms of a formal presentation, but really hoping and glad that we have, it looks like, a little less than a half hour left in the webinar to really delve into some of your questions, either about the quality measures themselves. Obviously, a lot to take in as it relates to how the sticks and carrots are laying out on all of these various pieces over the next few years. Obviously, they've already started, but they're getting more and more complicated, and I think more and more incentivizing, certainly, to be getting on top of doing these things. So I guess I want to just open it up to questions now. Simone and I will both be on the line, so we can definitely address any questions folks might have about this talk on quality.
Thank you, David. Thank you, Simone. Ladies and gentlemen, to ask a question via the web presentation, please select the chat pod located in the lower left corner of your screen and then type and send your message. If you wish to ask a question live via the phone, please press star 1 on your telephone keypad. I will announce each caller prior to bringing you into the conference. Please remember, if you have your phone on mute, to take it off of mute when you're selected to ask your question. Once again, to ask a question via the web presentation, select the chat pod in the lower left corner of your screen. The drop-down menu you can put to Q&A. And if you want to ask a live question, you can press star 1 on your telephone keypad now. So David and Simone, I will start with some chatted questions that came in.
Okay.
The first one says, please clarify how the Medicare penalties/bonuses will be applied. Assume a hospital sees 10 fracture patients a year and Medicare reimburses $100 per operation. Total Medicare reimbursement is $1,000 per year for hospitalization for fractures. The hospital's total annual Medicare reimbursement is $1 million. Is there a 2% penalty? Is that 2% of the $1,000, which is basically $20, or 2% of the $1 million, which is $20,000?
Simone, do you want to start with that one?
Yes. Hi, everyone. This is Simone Carpet. I'm also joined by Ariane Pulaski, who is the CE City Director of Provider Products and Services, who is also going to participate in our Q&A this afternoon. So I'm going to turn that one over to Ariane to address.
Sure. It's a really great question, and I'm going to try and give you a really great answer for it. The incentives and penalties really apply based on the size of your tax ID. So assuming that it's a hospital and that there's over 100 providers within that tax ID, the amount at risk between PQRS and the value-based modifier combined is actually 6.5%. So that 2% you were mentioning is actually 6.5%, and it's of the total Medicare billing for that tax ID, not just those for those services. So it would actually be a much larger amount. If we were using your 2% example, it would be more along the lines of the $20,000, but it's actually a 6.5%. So you're looking at something much larger in terms of what's at risk in 2014.
Thank you. Our next question asks, let's see, which of the 3 measures was not accepted? Sorry, I missed that. Also, Simone, they're interested in getting the slides. And you know what, ladies and gentlemen? I believe those should be loaded in handouts. I can see if I can get that done.
Actually, no, we didn't load these in handouts. So, I mean, once people get the on-demand, they'll be able to see the slides as well as those business case slides that I indicated are up on Fracture Prevention Central now. So that's kind of the mechanism to get the information that we presented today. But I will answer the question about the measures, and sorry to not be clear. So the first 2 measures were the ones that were endorsed. The lab investigation for secondary causes, the risk assessment treatment. The one that was not endorsed was a third one on discharge instructions in the emergency department. Really, the group felt like there wasn't enough scientific clinical evidence. To me, it's just kind of, common sense that, of course, having better discharge instructions will lead to better outcomes in terms of empowering the patient to kind of take the next step once they're out of the hospital. But that one was not endorsed. So if the Joint Commission does indeed create a new core measure set, it would consist of these 2 measures, Measure 1 and Measure 2.
Thank you, David. The next question asks, this particular participant is not exactly clear on how the joint effort with NCQA registry will work, meaning who is qualified to request joining the reporting effort and what will be required of them.
I think they're referencing the QCDR registry. So how that will work, and maybe I'll let Ariana talk some more about this as well, is that over the next few months we're developing kind of a portal way that you're going to be able to submit your quality measure data. I don't know if maybe you want to take it from there, Ariane.
So this is Simone. I'm going to go back and show everyone the slide, we already have it where you're able to come in and pre-register for the QCDR and let our organizations know that you will be interested in participating in the QCDR. And if you just come in, this is the URL. I'll leave it up here so that you can copy it down. If you just go to that medconcert/FractureQIR website and click pre-register, we'll notify you when the QCDR is live for you to be able to participate in it. What will be required is the ability to have the data either uploaded or input right in through the web. We're going to give multiple options for the data entry into the Qualified Clinical Data Registry, and then everything else from there is automated for you. CE City's technology solution will provide you with daily feedbacks on your data versus the measures, so you can see your performance on a daily basis. And we'll also provide all of the services to submit the data on your behalf as the qualified registry to CMS for the PQRS reporting.
Thank you, Simone. And the next question asks, is there a cost associated with this registry?
Yes, there will be a cost.
Okay. And the next question asks, for increased reimbursement, would practices have to report data on all of the following: PQRS, VBM, and QCDR? That seems like a lot of data to report.
Yes, so this is Simone. I'll take that. So the answer is no. You only have to report in the Qualified Clinical Data Registry. So the QCDR, or the Qualified Clinical Data Registry, is all you have to participate in, and then the Qualified Clinical Data Registry and the technology solution will provide the reporting to CMS to satisfy both the PQRS requirement as well as the value-based modifier requirement.
Okay, thank you. Our next question asks, how many of the Joint Commission core measures sets must the institution select and show performance for in order to avoid penalty?
Yeah, so this relates to reaccreditation of a hospital with the Joint Commission. So as I understand, there are 14 core measures right now. If this osteoporosis core measure set becomes a 15th, what you would need to report on is 6 of the 15. So certainly not everyone will have to report on osteoporosis, but I guess our feeling is that having that among the groups to report out on, and given that honestly, compared to some of the other disease states, this is a pretty straightforward one to get your arms around, that will really help seed a lot of new programs that maybe don't exist right now, as especially the administrators who, of course, are very motivated when it comes to reaccreditation time to perform well, get through that process and successfully. So really, that's kind of our goal is if we can have that as a new mechanism to kind of wake up on the business case side. I think that will really be helpful if that happens as of next year.
And David, if I could add on, because I think it's almost a two-part question that's being asked. One is related to the Joint Commission core measures, but it sounds like the second part of the question was related to avoiding the penalty. And I'm assuming that you were referring to the financial penalty. And the answer to that would be 9 of the measures from the 14 measures in the QCDR. And what our registry-based solution will show the organization is if you've met the requirements necessary in order to submit the data to CMS. And so the registry will help you to track all of that. So there's a total of 14 measures in the QCDR. The minimum requirement for 2014 is 9.
Thank you, Simone. And Simone, can you just reiterate, so are there fees involved for using the registry or fees involved for registering?
There's fees involved for for utilization of the registry. So
Okay.
once you register for the registry, and that is an all-inclusive fee to use it as a continuous quality improvement registry, as well as the submission of data to CMS for the quality reporting requirement.
Thank you very much for clearing that up. And our next question's asked, if you are already receiving EMR reimbursement, can you also receive the 2% reimbursement for PQRS?
Yes, so the answer to that is yes. So the EMR reimbursement falls under your meaningful use. The meaningful use program would be in addition to the PQRS program. PQRS requirement being fulfilled is what is being utilized for the value-based modifier. So it's actually more than 2%. Depending on the size of your practice, it could be up to 6.5%.
Fabulous. Thank you very much. At this time, I don't have any other questions. But David, once again, would you mind telling folks how they can get a copy of these slides? I have another question as to how they can see these slides so they'll know what measures that they need to submit if they volunteer for the registry.
Sure, and I think the best mechanism to do that, because obviously folks are very excited, which is great, is that I can work with Simone, and when we push out the on-demand instructions, we can also push out a specific link where the slides are. There may be a few that we may not be able to include in the public deck, but we'll definitely have a version that we can push out, especially related to the QCDR. And all the pieces that I presented obviously are already up on Fracture Prevention Central, but just need to go through that to make sure that these are all ones that we can have out in the general public. But definitely want to keep the excitement, keep the enthusiasm going around this, and obviously these are also tools that you'll be able to use individually as you have these conversations within your institutions.
Thank you, David. We did have another question pop in. It
Okay.
asks, many hospitals meet 9 out of 14 core measures reporting. If a hospital reports osteoporosis core measures as the 10th, is there a potential bonus?
That's one I don't know the answer to. Certainly we're working directly with folks at the Joint Commission as we move these measures forward, so I can ask about that. I mean, the last conversation I had with them, my understanding was that at minimum a hospital just had to report out on 6 of the measures, but we can definitely try to find that answer for folks, because that's important, and of course it would be another incentive if that was the case.
Thank you, David.
And this is Simone. I also, for anyone who would like to review the measures in the QCDR today, I put that website back up. We have all of the measures listed on that website as well.
Right.
Fabulous. And at this time, David, there are no other questions, so I'm going to turn the program back to you for any final thoughts.
Okay, great. Thanks so much. We'll really appreciate everyone's time, enthusiasm, especially want to thank Simone Karp for her participation in today's webinar. It's really been great to work with her over the last year or so, and with all the other folks at CE City. As you can see, she's a font of knowledge, and I've learned a lot about kind of where this where quality is moving, and having done quality work 15 years ago, to really see how it's evolved from people doing it for the right, just for the right reasons for the patients, but now really having this financial piece. So obviously it's very critical to understand the nuances of this and understand what's coming down the pike so you can be prepared. And certainly I think from our perspective in osteoporosis, having this new QCDR is really going to allow us to get lots of other folks pushing this forward, and I know everyone's doing a great job of really spreading the word around the community. So just want to thank everyone for their time. Certainly, as we said, we'll pull together a public version of this deck that we'll send directly to all the folks that registered to participate today. And we should, usually within a week, we have the on-demand version of the webinar available, so that would be the audio that would be synced with the slides, so you'll be able to look at this again for folks that you might want to push it out to other colleagues that weren't able to be on today. But just want to really thank everyone for all of their efforts, support, really feeling like this is a movement now, and really feeling the enthusiasm, and that we're moving this very rapidly because of everyone that's pushing in the same direction. So just wanted to thank everyone. Have a great day.
Thank you, David, and thank you, Simone. Ladies and gentlemen, this is the conclusion of Healthcare Quality 101, What, Why, and How. We hope you have enjoyed this session. You may now disconnect.